Hello everyone, Assalamu alaikum. Welcome to another pyramid video. My name is Karim Darwish, and inshallah I'll be walking you guys through the histology of the upper respiratory tract for our CVP block. Inshallah, without further ado, let's go ahead and get started. So this is the objectives for the lecture. I know that there is more written on the slides, but I kind of condensed them so it doesn't look as intimidating. This will be a little bit somewhat of a long lecture, but inshallah I'll try to get through the easy stuff quickly so that way we can focus on what's important. I just want to preface this by saying that for histology there's no trick or mnemonic that I will be giving you to help you memorize, and I will just give you the ideas to understand the function of each thing, the function and how it relates to the structure. It's something that I always tell everyone is that structure is always going to determine function. Okay, and if you understand the basic structure of where I'm talking about and what I'm talking about, the function is going to come along with it. You know, if I tell you, for example, mucus, you know, is going to be released by goblet cells. And you know that goblet cells are going to be in the upper portion of the respiratory tract. It's not going to be in the lower. You know, but I'm going to give you key features and things like that to help you with the histology. And I'm a fan of histology. I don't think histology is too annoying. A little bit of a controversy there, but you know, inshallah, I will do my best to kind of share that with you, inshallah. So without further ado, let's go ahead and just get into the lecture. So a quick overview before we get into things. The respiratory system has many different functions. Some we've talked about, such as gas exchange, which is being the most crucial, air conduction, filtration, speech, smelling sensation, endocrine function, regulation of immune system, and inhaled antigen. Things that we've discussed already in class. Yeah, today's lecture is not to talk about the function, but rather the structure and how things look under a microscope. So we split the respiratory system into two sections, the upper and the lower. The upper is going to be composed of the nasal cavity, the paranasal sinuses, and the pharynx. These develop embryologically, from the primitive oral cavity. That's going to be for Dr. Paul to explain, not me. The lower respiratory tract is going to be formed by the larynx, trachea, bronchi with their divisions, lungs, and they develop from the foregut, endoderm, and its surrounding mesenchyme. I hope I pronounced that correctly. Okay, so we're going to again have it two different categories, conducting portion and respiratory portion. Conducting is going to be nasal cavity, pharynx, larynx, trachea, bronchi, bronchioles, and terminal bronchioles. Okay, their function is going to be clean and humidify air and provide ways to aid in air movement. Okay, while the respiratory portion is going to be the respiratory bronchioles, alveolar ducts, and alveoli, and this is where the gas exchange is going to take place. Okay, now we're going to talk about the first portion, the nasal cavity. There's three parts that we're going to talk about. It's basically the nasal cavity is a paired chamber separated by a bony cartilage and a nasal septum. Okay, I apologize, bony and cartilaginous nasal septum. Okay, we're going to split it into three parts: the vestibule, the respiratory region, and the olfactory region. Okay, as you notice here, I want you to notice the respiratory region makes up majority of the nasal cavity. Okay, we know that the nasal vestibule, which is this green area right here, is going to be lined by stratified squamous epithelium. Okay, and then the respiratory region is going to be lined by respiratory mucosa, and the olfactory is going to be lined by specialized olfactory mucosa, and we'll discuss each one in further detail as we get to them. Okay, so the vestibules of the nasal cavity, it's a dilated space inside the nostril, part of the external nose. Okay, it's going to be lined with stratified squamous epithelium. Okay, just like your skin. It's going to contain something coarsa, which are moist hairs. These is going to have sweat and sebaceous glands. Posteriorly, the epithelium is going to transition. At the front it's going to be stratified squamous, and it's going to transition to become pseudostratified columnar, because we know that the respiratory epithelium is pseudostratified columnar. Okay, but if you notice here, this is the sebaceous glands, the vestibular follicles. Okay, so this is where we are in the vestibule. Okay, but this is the vestibule, and I want you to just notice this is the skin. So this is going to be stratified squamous, correct? Because this is skin. Skin is going to be stratified squamous, and as we transition, getting into it deeper, it doesn't show it here, I don't believe. It's going to be pseudostratified columnar epithelium. So far, I think pretty easy, straightforward, nothing too difficult yet. Okay, now, so I want to look at the structure for a little bit. So in the respiratory region, we said that the respiratory region is going to be the largest part of the nasal cavity, like we discussed. That was the red portion. Okay, it's going to be lined by respiratory mucosa, because now we're breathing, so we want to make the air moist. We want to filter the air, right? For the medial wall is going to be the septum. The septum is going to separate in the middle. Okay, the lateral walls, we're going to have three structures called superior, middle, and inferior nasal conchae. You guys see here these little swirls? Yeah, basically their function is going to turbulate the air, increase the surface area, and create airflow turbulence. Okay, what does that mean? So when you breathe in, the air is going to come in here and it's going to some sort of like do a swirl. Okay, this swirl is going to help force the air in and kind of give it that easy access to flow. Okay, we are also going to be increasing the surface area so that more air can come in. So for example, if you have all this space filled with air versus just a straight wall, we're increasing the surface area. Anytime you increase the surface area, you're absorbing more, you're taking more in. Okay, same idea here. Okay, let's take a look here. Okay, we're gonna take it step by step, nothing too difficult yet. Okay, and then we said it's going to be what? Respiratory mucosa consists, okay, of epithelium. We see here the pseudostratified with the cilia, okay, respiratory epithelium. Nothing too difficult. These white spaces, these are goblet cells. You guys see this long, these are goblet cells. And here there's another photo of them. You guys can see here that this is a goblet cell, this is a goblet cell, goblet cell, goblet cell, goblet cell, goblet cell. Then under it you're going to have the basement membrane. Okay, here you're gonna have the red blood vessels. Excuse me. You're gonna have blood vessels here. Okay, and the A is for adventitia. We're gonna discuss that later. So here, respiratory is gonna consist of epithelium and lamina propria. Respiratory epithelium is pseudostratified columnar ciliated type, and then here we have the tall columnar cells with motile cilia projection into the mucus. Because goblet cells here, anytime you see goblet cells, there's mucus. For these cilia are going to help push the mucus. Okay, function as a mucociliary escalator. They help push the mucus, like I've been saying, trap the particles in the mucus and move them towards the throat to be swallowed or expelled. So far, so good, everyone. I think nothing too difficult yet. Okay, now, I want to talk about two different types of cells. We're gonna have small granule cells and basal stem cells. Okay, from the name of small granule cells, they're going to contain granules. Okay, they resemble basal cells that contain secretory granules. Okay, as you can see, they're the purple ones here. These purple ones. See these little dots inside? These are the granules. Okay, they function as an endocrine cell for the diffuse neuroendocrine system. We have not talked about that yet, but it's just for you notice. They release granules, and when we talked about the respiratory system has endocrine qualities, this is what we meant. Okay. Now we're going to talk about something about these. They don't reach the surface. Okay, but if you see a cell on the surface, that's not going to be the small granule or the basal cells, which we'll talk about now. Basal cells, they don't contact the epithelial surface. Okay, they divide to form epithelial cell types. They're a form of stem cell. Okay, they become the regenerative cell of the respiratory epithelium. You see them here. Okay, also don't reach. This is a goblet cell. We already talked about it. Brush cell, it will come in the future, inshallah. You guys see the goblet cells. Goblet cells are not tiny. They're like span. Okay, to produce mucus. Okay, so far so good. Okay, so now you've been hearing me talk about lamina propria. What is lamina propria? Lamina propria firmly attaches to the periosteum. Okay, and the perichondrium of nearby bone and cartilage of the skeletal support. Fine. So basically, what I want you to know, the lamina propria is a living cushion. Okay, under the epithelium, giving it support, nourishment, and immune protection. Okay, it's made of loose connective tissue with a rich vascular network. Rich vascular network. Okay, so it's going to provide warmth and humidity to the inhaled air. Because we said that it's going to, in the previous lecture that I gave, I talked about how the blood vessels are the blood is going to help warm the mucus, and the mucus is going to help moisten the air. Same idea here. The lamina propria is just a cushioning. Okay, contains mucus glands, often with serous that aid mucus secretion and assist in air conditioning. I also want to excuse myself, guys, and I have allergies. If my voice sounds muffled, my nasal cavities are currently my nose is currently struggling. Okay, I hope that's not interfering with anything too much. But yeah, the lamina propria, what I want you to know, is a living cushion under the epithelium, giving it support, nourishment, and immune protection. Okay, now, respiratory region of the nasal region. We're talking about how we're conditioning the inhaled air, we're warming it via vascular network in the lamina propria. The same thing we've discussed before. We're going to moisten it, add humidity to the inhaled air. We're going to remove particles. The mucus is going to help capture molecules. The hairs is going to capture molecules as well. The brucei, I think that's how you say it. And local immune response. We're going to contain lymphocytes, macrophages, and mast cells. Okay, as we see here, we have the blood, the vessels, and respiratory epithelium. Okay, same thing that we've been talking about. Really, nothing too difficult yet. Nothing really out of the ordinary. Okay, now we're done with the nasal region. We're going to talk about the olfactory. So we talked about the vestibule, we talked about the respiratory region. Now we're going to talk about the olfactory region. Okay, so the olfactory region was the bit at the top that we saw, makes the upper 1/3. Okay, so it's specialized olfactory mucosa. What does that mean? This is the area that is in charge of smell. And when you smell, this is a sensory thing. But you're going to have something that is involved with sense, with sensing. Okay, so we're going to talk about that. Okay, so the specialized olfactory mucosa is going to be olfactory epithelium without goblet cells and lamina propria. Okay, the function, detection of odor. Okay, it's a pseudostratified columnar epithelium composed of olfactory receptor cells. These are bipolar neurons spanning the epithelium of the CNS. Okay, you see all of these olfactory cells. These are they're bipolar. These have bipolar neurons. Okay. They are bipolar neurons, okay, that span the epithelium to the central nervous system. The apical projection with emotal cilia, okay, so you see these are emotal cilia. This is just, it's sensing, we're smelling something, okay. Olfactory receptors located on the cilia membrane. Okay, you see, I see these cilia right here. I can't zoom in, but like here, these lines. These on them, they're gonna have receptors that are gonna sense smell, okay, supporting sunticular cells, okay. Basically, what are these? They're columnar cells providing mechanical and metabolic support, synthesis, and secrete odorant binding protein. Okay? When I ask you, the supporting cells, what is their function? You could just tell me that they're a columnar cell, provide mechanical and metabolic support, and they secrete odorant binding protein. Odorant means smell. Okay? Bye. Basal cells, they're stem cells, like we said, for olfactory receptors and supporting brush cells. Okay, things that we've already been mentioning. Okay, move on. طيب. Now, paranasal sinuses, easiest part of the lecture. Sinuses are empty spaces. Okay, they're paired, air-filled spaces in the skull, in the bones. Okay, there's the four main ones that we know: maxillary, nasal, the ethmoid, sphenoid, and frontal. Basically, their function is to just decrease the weight of the skull. Okay, because if you have everything hard, compact bone, your skull is going to be very heavy for your spine to carry. So we add, subhanallah, we have empty spaces that help reduce the weight. Okay, they add resonance to the voice, so you have an amplification, so you can kind of hear yourself in a way. Okay, they have mucus. They have some mucus secreted, not too much. They have some mucus secreted that moistens the area, and it cleans the nasal cavity surfaces, and it drains. So the mucus in here drains with tears through the nasolacrimal duct. Okay, and that was mentioned a lot in lab. For inshallah, when you guys are reviewing lab, just make sure you guys connect that dot here. So we said that they're paired. We have the frontal, ethmoidal, sphenoidal, and maxillary, and they communicate with the nasal cavity via narrow openings lined with respiratory epithelium, thin lamina propria with few small mucus glands drain into the nasal cavity. Okay, nothing too wild there. Okay, so now we're going to shift our focus down to the pharynx. The pharynx is going to connect the nasal and oral cavities to the larynx and the esophagus. Okay, here it serves as a passageway for both air and food. Okay, so here we have, it's split into three. We have the nasopharynx, oropharynx, and the laryngopharynx. Okay, the nasopharynx is going to be in the nasal cavity, located posterior to the nasal cavity, connected with the middle ears by tubes. We have not talked about that, lined by respiratory epithelium. Same thing that we've been talking about. Oropharynx is going to be located posterior to the oral cavity, lined by stratified squamous epithelium, because we said that the pharynx is gonna both take air and food. Okay, and then the laryngopharynx is posterior to the larynx, lined by stratified squamous epithelium. Okay, I don't think there's really anything too much to talk about here, except just know the divisions of the pharynx, and that the pharynx connects the oral cavity to the larynx and the esophagus, and it serves passageway for both air and food. Okay, so now the larynx. So now we're going to be talking about the larynx. The larynx is the passageway for air, just air, okay, between the pharynx and the trachea. Okay, it's irregular musculocartilaginous tube, okay, lined with mucous membrane. Okay, epithelium and lamina propria. Okay, just I want you to know this. It's made up of epithelium and lamina propria. The function: produce sounds, okay, and maintain an open airway. Prevents foreign objects from entering the lower respiratory tract by something that we're going to talk about, known as the epiglottis. We'll discuss that, I believe, after a couple more slides. Okay, so this is here what I want you to focus on. This is also a picture in your lab. If you know this now, might as well also help you. The larynx, so you have here this cartilage. This is the thyroid cartilage and then the coracoid cartilage. Okay, this is the anterior view. The epiglottis is right here. This is what we're going to discuss this in the next slide, I believe. And the posterior view, you have the cuneiform, you have the chroniculate, and then the arytenoid. Okay, the arytenoid is like the little horns, and then the horns on top of the little horns right here, these are the corniculate. Okay, we do need to know this for lab. If you know this from lecture, kudos to you. You already are way ahead. Okay. So let's take a look at what I've written here. Formed by irregularly shaped hyaline cartilage and elastic cartilage. You need to know what type of cartilage that makes these up. Hyaline cartilage forms the thyroid, coracoid, and part of the arytenoid. The elastic cartilage produces the epiglottis, vocal processes, of the arytenoid, and the cuneiform and corniculate. Okay. Then we have here the cartilage is connected by joints, ligaments, and membranes. Movements controlled by intrinsic laryngeal muscles. Okay. Again, very, very easy, very lab oriented. This is stuff that we've taken in lab. Okay, now let's discuss the epiglottis. Okay, the epiglottis is a flattened surface projection from the upper rim of the larynx. Okay, its function, it's like a gateway. It's like a bab. I think of it as like a bab, like it opens and closes. Okay, the surface is a lingual surface covered with the stratified squamous epithelium. Laryngeal surface is the stratified squamous epithelium transitioning to pseudostratified ciliated columnar epithelium. I want you to really focus on this part, and I'm going to repeat this part one more time. Laryngeal surface, okay, if you have a lingual surface, is going to be towards the tongue, the upper part, okay? The laryngeal surface is going to be towards the larynx, okay? Okay, just like as you see here, lingual surface is going to be towards the tongue, and laryngeal surface is going to be towards the larynx, okay? The laryngeal surface is a stratified squamous epithelium, and it's going to transition to pseudostratified ciliated columnar. And we're going to look at that in the histology slide in a bit, okay? But I want you to notice this, just like how we said before in the nasal cavity, how we transition from stratified squamous to pseudostratified. Same thing here. We're going to go from stratified squamous epithelium to transition to pseudostratified columnar epithelium, okay? Subepithelial glands, they mixed mucoserous glands present beneath the epithelium. Okay, that's it. I really just want you to focus on this part right here. This part is very important. These surfaces, this is very important because we're in histology, so we want to know what the cells are made up of. The epiglottis function is also very important to know, but my job is just to focus with you on these two here. Okay, before everyone gets so scared and terrified, we're going to take it step at a time. Okay, so this is the laryngeal surface, which is going to be facing towards the larynx. The larynx is going to be here. Lingual surface is the tongue is going to be here somewhere. Okay. They form stratified squamous epithelium protective non-keratinized. Non-keratinized is important. Anytime you see keratin, it's going to be skin, hair, nails. Non-keratin, you can't have keratin inside because if you have keratin is rough, it's hard. If it doesn't make sense to have it in a place that needs to be flexible to open and close. Okay? So we start off stratified squamous, non-keratinized epithelium, to pseudostratified ciliated columnar with goblet cells. Okay? So here we're going to look at the linguinal surface. Here we start off with stratified like we said. Okay? And then we're going to continue, same thing here. And here this is where the laryngeal surface starts. And this is where the transition happens. So now we're going to switch from stratified squamous, we're going to have what? Pseudostratified ciliated here. Okay? The respiratory epithelium is going to start here. This is the top, okay? And we're going to continue stratified squamous, transition, we're going to become respiratory epithelium, it's going to be pseudostratified cilia. Okay, and inside here you have the serum mucus glands. Okay, I think so far very easy. Nothing too difficult. Okay, pseudostratified here, simple squamous, non-keratinized. If there was keratin, there would be pink here, non-keratinized. Okay. Right now, vocal cords. This is how me and you can speak, and this is how you can hear me, because this is how my voice is being produced. Okay, this is the epiglottis that we talked about. See, it doesn't look like a very rigid structure. It looks like a very smooth structure. Okay, so now we're going to talk about this. The laryngeal cavity. Okay, now it's going to be lined by mucosa because you don't want to have a dry. This area you do not want it to be dry because this area, if it's dry, it's going to be hoarseness in motion. Okay, it's going to form two pairs of folds separated by ventricle, mucosal invagination. You guys see here. This is the ventricle right here. You see there's a small fold at the top and then another fold at the bottom. Okay, so we're going to have two sets of vocal cords, false and true. Not actually two sets of vocal cords, but you have a false vocal cord and the true vocal cord. The false vocal cord is a vestibular fold. You see right here, these are the false. These are not what produce the motion or like the speech. Okay, contain numerous serum mucosal glands covered with respiratory epithelium. Their upper pair are immobile. Do you guys see this part? This part is not what moves. These are what move. The vocal cords, the vocal folds are what actually move. Okay, these are what we call true vocal cords. This yellow part, true. Red is the false. Okay, they are the lower pair. You see here? I want you to see how they're like lower here. Okay, a little bit vestibular folds here, and you see the vocal folds right here. Okay, they are mobile, responsible for sound production. Phonation is just the pronunciation and like vocalization of the words and the voices, the audio of like your voice. Okay, I hope I didn't confuse you guys there. Okay, now vocal cords, the true vocal cords, we're going to talk about things that actually produce motion. We have epithelium, non-keratinized, stratified squamous. Okay, again, non-keratinized. They resist mechanical stress and vibration friction. Okay, following each other. They have superficial lamina propria. Okay, lamina propria, you guys see the lamina propria here? Is much more superficial. It's like directly under the stratified squamous. Okay, right. Now, the vocal ligament is a dense, regular, elastic connective tissue. The vocal ligament we will discuss. It's a ligament. It's a connection. We know ligaments connect things. Okay, so here it's connecting. We're connecting the lamina propria with the muscle. Okay, through the vocal ligament. You know, now the vocalis muscle is a striated muscle bundle, regulates tension of the folds and ligaments. We're regulating how much tension and how much force we're pulling on against the vocal fold. Okay, modulates pitch and frequency of sound. Then when your sound goes up, when you scream, for example, you get very high pitched. This muscle would stretch more, or widen more, or contract more. Okay, versus if you go very deep pitch and you go like a growl almost, and you like تعمل صوت deep, صوت تقيل, صوت خشن, they will move differently. For this muscle, it's gonna change and it's gonna shift its contraction based on how much the pitch, and it controls pitch. How, if you go high or low, not the volume, high pitch or like a scream صوت عالي أو صوت إيش, صوت deep or what's the other word? High frequency, like zzz. You guys know what I'm talking about? I hope so. Inshallah, and inshallah that made sense. Okay, I want you to know here, vocal folds. You have the ligament, which connects the lamina propria with the vocalis muscle. The vocalis muscle is going to control pitch and sound. Okay, again, here we're going to walk with each other, not to be scared at all. Very, very easy. Here, the muscle, we know muscle is going to be deep, right? For this red part here, this is what the muscles look like. This is the vocalis muscle that's going to control what? The pitch. Here, we have the serum mucus gland. This is the false. False is going to have mucus. True does not have mucus. True has muscle. Okay? Now, here, this blue part is the respiratory epithelium that we have. Remember? And then we're going to transition into having... There's no transition. It's kind of... This one has it and this one doesn't. Here's just no transition. I apologize if I said the transition. Here, there's no transition. Here, for this one here, you just have respiratory epithelium, the pseudostratified cilia, and then here you have the non-keratinized stratified squamous in the true. So when there's muscle, you have stratified squamous. When there is sebaceous serum mucus glands, you have respiratory epithelium. Remember, mucus with respiratory epithelium. Okay? Remember it like this. Okay? I hope my thing works. Okay. Inshallah, we're almost done. It's very, very simple. We have about like 5 slides left, inshallah. The trachea, we know. Trachea is very, very simple. We know it's a short, flexible tube, 10 to 12 centimeters long with the 2.5, I think it was, diameter that we talked about in the previous lecture that I gave. It extends from the larynx to the carina. Carina. What the carina is basically where the bifurcation. It's like this. It's like the division between the right and left bronchi, where it divides into 2 primary bronchi, as I just mentioned. The function is a conduit for air. Conduit it's like a tariq, but it's like a street. It allows for the passage of air. The walls help condition inspired air. The walls of the trachea, here as you see, they're going to help condition the air, make sure it's fit, make sure it's good quality for the lungs. The lumen remains open due to series of cartilaginous rings. We know that the trachea has C-shaped rings. They help it from collapsing. Okay, they keep it open. Why don't you need it in the back? Because you have the esophagus in the back. Correct? Because you have the esophagus in the back, it's kind of almost pushing it, keeping it open. But you don't really need cartilage in the back. That's why you have C-shaped hyaline cartilage. Okay? Moving along. Okay, so now here, we have respiratory epithelium again. We have a basement membrane again. Lamina propria again, because we said lamina propria is more superficial here. Blood vessels, okay? And then we're gonna continue to talk about this now. So we have mucosa. There's 4 things I want to talk about. Mucosa, the ciliated pseudostratified columnar epithelium, okay? Thick basement membrane with densely packed collagen fibers. Lamina propria, okay? Loose connective tissue, resting elastic collagen fibers, like we said. We have lymphocytes, plasma cells, fibroblast. Contains the bulk, okay? Bronchus-associated lymphoid tissue. This whole section right here, okay? All of this is going to be the mucosa. Okay? Mucosa. Now, we're going to shift over to submucosa. So everything, lamina propria, basement membrane, and epithelium, these are the mucosa. Now, we're going to talk about the submucosa, where it's going to start a little lower. We're going to have loose connective tissue, like we said, loose connective tissue, dense loose connective tissue, and we're going to have the boundaries, elastic membrane. We're going to have elastic membrane here, okay? This is where we're going to start. EM is elastic membrane. Here we're going to start having the submucosa, okay? We're going to contain diffuse lymphatic tissue, lymphatic nodules, more blood vessels. We're going to house something called the houses larger distributing blood vessels. We have bigger blood vessels, okay? We have mucus secreting glands. All of these, again, they're going to be in the submucosa, okay? Now, again, quick recap. We have here, as we said, we're going to have here epithelium, lamina propria, blood vessels, and glands. Okay, moving forward, I want to continue before my time runs out. 3 cartilaginous rings, 16 to 20 C-shaped hyaline cartilage rings, provide flexibility and maintains lumen patency. Open posteriorly against the esophagus. As I said, this is the same thing here, that the esophagus helps keep it open, and we don't need it as much. Okay. Then you have the adventitia. Adventitia is a loose connective tissue, binds the trachea to the adjacent structures. You have the trachealis muscle, relaxes during swallowing to facilitate the passage of food by allowing the esophagus to bulge into the lumen of the trachea. Basically, this is just telling you that the point is that there's no cartilage in the back, is that the muscle, the trachealis muscle, is going to relax when you're swallowing, and it's going to help push the food down. It's going to let the esophagus to bulge into the lumen. Here you see here, but the esophagus is going to bulge here a little bit to cause this, so that way you can swallow your food. Okay? And that adventitia, as we said, is a loose connective tissue, binds the trachea to adjacent structures. Okay, the clinical significance, I won't take too much time spending on this. Hello, sorry, I had the video cut off and I had to add another clip. But I'm just going to try to finish quickly as possible. This is the last slide and it just cut off. Unfortunate, but what can we do? So, the clinical significance of this, we're going to talk about a couple of common respiratory inflammations. We're going to have rhinitis, sinusitis, pharyngitis, adenoiditis, laryngitis. So, it's common upper respiratory inflammation site. Okay, for rhinitis, the one I need you to know is a vascular network in the lamina propria becomes engorged and leaky. So they become very leaky and they start releasing things. Okay, it causes mucosal swelling. That they become swollen. Anytime you see the word itis, I want you to think of something is becoming swollen. Okay, airway is going to be restricted, obviously, because something is swollen. Difficulty breathing. Okay, SARS and COVID-2 induced insomnia. The virus bind to and depletes supporting cells in olfactory epithelium. Epithelial stop smelling. For example, that's why people who had COVID, they lost their sense of smell because it depletes the surrounding cells. Okay, that's what I need you to know. And usually, it transients with sense of smell restored within usually about 10 days. Okay, Singer's nodule is a benign reactive polyp. Okay, commonly occurs in stratified squamous epithelium of true vocal cords, affects the voice. If you see here, these are Singer's nodules. It happens because of reactive polyp. Okay, I don't believe that they talked about what polyp was, but if you are interested, you can feel free to do your own research on that. And I had a note somewhere, but I lost it. But what I want you to know that Ringer syndrome it causes a little protrusions here. Okay. And that's it. Thank you guys so much for watching. I hope this again helped you guys in preparation for the final. Good luck on your final as well in that topic. I wish you all the best, inshallah. If you guys need anything, please feel free to reach out. And that's it. I hope you guys enjoyed. Kimo signing out. Assalamu alaikum.